go.
Hi, I am doing the CBI and intermittent bladder irrigation for the skills fair. So this is if obviously you missed coming to the station. So I want to start out by talking about continuous bladder irrigation. There are several reasons why you might need this. One is status post TURP, which is transurethral resection of the prostate. Status post prostatectomy, status post cystoscopy, the patient has hemorrhagic cystitis, or just really bad hematuria. So you do want to get supplies gathered. You are going to use normal saline as the irrigating solution. It comes in these 3-liter bags. It also comes in 1-liter bags, but the 3-liter bags make more sense because that way you're not having to go in and put a new bag up frequently, especially in the beginning when you're using a lot of this to clear the urine. You're obviously going to need gloves. You are going to need alcohol wipes. I suggest using one of these bigger basins. I don't feel like the Emesis basins are big enough. You're going to need normal saline later when we hand irrigate. And then you're obviously going to need a chucks because this is going to be messy. So you are going to get the pad wet. So in order to not have to change the pad, just put a chucks down. You are going to need an IV pole, and you're going to need this tubing, which I don't have it in the package, but essentially it looks a lot like IV tubing. It has a big roller clamp and just the spike, and then the part that goes into the catheter. All right, so the first thing we want to do is we're going to see that we have an order for this. If the patient comes to us with it already running, great. If not, you want to obviously make sure that they have a 3-way catheter. So essentially it looks like this. We have the port that fills the balloon that keeps it in place, and then the center is for the Foley bag, the drainage bag, and then this smaller port on the side is for the CBI tubing, and it's always going to go in that. It's always going to be this way. So you are going to verify they have the 3-way, check the order. Sometimes they may come to you with sorbitol running, and if that's the case, you want to let all of that go through, and then you would check the order, and the doctor should be ordering normal saline to be the next solution that goes in. And it's also possible that the patient's electrolytes may be drawn in the PACU, and you do want to let the doctor know if the sodium is less than 130. You're going to quickly assess your patient for signs of fluid retention that can lead to harmful cardiovascular effects. So listen to their lungs, check for swelling, let the doctor know if you notice that. So get all of your equipment. You're going to explain to the patient what you're going to do. If they already have it running, fine, but if you're setting it up for the first time, and even if they do have it running, maybe ask, hey, did the doctor explain why you have this going and what to expect? And if you know why you're doing it, then let them know that. Hopefully you do know why. You're going to wash your hands. You are going to palpate the bladder. So you want to feel if the bladder seems distended, if the patient seems to be having any distress when you push. You really should, before you get the CBI running, if it isn't already running, you really should hand irrigate a little to get the urine as clear as possible. You have to assume that there's probably some clots in there. So if you can hand irrigate to the point where you get it pretty clear, pretty light, and then set up your CBI, you're probably going to have a lot more success. Ideally, the bladder should be as empty as possible. If it is not already running, you're setting it up, you do want to make sure you empty the Foley because obviously there's urine in there. And where we're starting all of this, we really have to be careful that we're documenting how much we're putting in, how much is coming out. So you want to start fresh. So you want to start with the drainage bag empty. So you would at that point, and obviously you're going to document how much is in the catheter. in the eyes and nose. And that is all urine if you are setting this up for the first time. So you're gonna put your gloves on after you washed your hands. So pretend this is still in the package. You're gonna take it out, you're gonna remove the safety, spike the bag. The roller clamp should be closed. And then you're gonna go over a trash can, you're gonna prime the tubing as you normally would, and then you're obviously going to connect it to this side port. So you are going to, you're never putting this on the pump, you're just going to open it up. And basically, you're just gonna get the drips to, if it's gonna work with my fake. Yep. So you just wanna have a steady drip. And basically, if it starts to get too fast, you wanna slow it down. I would say you just start with a steady drip, and what you are doing is you are frequently monitoring to see what color is the output. So obviously it's urine mixed with the saline. And the goal is to get it light pink. The goal is to get it clear, but light pink is great. If after, a little bit, you still see really dark red urine or output, you're going to increase this. If it really starts to lighten up, you can slow it down. So you're really constantly keeping an eye on this and having to make adjustments. The problem with not having it be light pink or clear as possible is that you're not getting enough saline in there, and that's when the clots tend to build up. So you really want to keep that, the blood that's in there to be as dilute as possible. So that's kind of something that you're just going to have to adjust and be constantly assessing. Typically it is 100 to 300 mLs an hour. So just so you know too, this is clean. This is a clean procedure, and you do need a doctor's order obviously for this. When you do go to hang a new bag, you're obviously going to use aseptic technique. This tubing is only good for 24 hours. You do want to make sure it's labeled. When you do go in the computer to document, it also gives a place to say when the tubing was hung, what the time and the date. So as you're doing this, once it gets started, you're gonna keep an eye on your patient. Is he complaining of pain? Do they have cramping, feeling anxious, pale, changes in cardiac status, cramping? All of those are signs that they're having a buildup of urine or some kind of a fluid shift. So basically, it's super important to, at least every hour, you should be checking on this, if not more frequently. Because if you are noticing that there is more going into the patient, I'm just gonna clamp this. If you notice that there is more going into the patient than coming out, then obviously there's an obstruction. So, obviously you wanna make sure, is the tubing kinked? Is it something silly like that? If not, you have to assume that there's probably a clot there. So at that point you would have to hand irrigate, which we will go into later. But it's super important to keep an eye on this. If for some reason you were like, well, I'm not quite sure, you can always bladder scan. You don't need a doctor's order to do that. Wicked easy, quick, awesome way to get an idea of what is sitting in the bladder. Let's see, I just don't wanna, so vital signs. You're also, in the very beginning when you first start, you are gonna do vital signs every hour times 2, then every 2 hours times 2, and then every 4 hours or as needed. You really wanna be emptying the bag at least every 4 hours. You might be doing it more frequently in the beginning when you're really sending a lot of saline into that bladder. And when you go to document, if you put in how much of the saline that went in, and then you document what came out of the drainage bag, it will automatically do the math for you to figure out what true urine was. And I do have an example of that on here. So just to show you, this is the order. This is what's going to come up when you hit the O. It does say, okay, we're going to do normal saline. We do have an order to irrigate to keep the effluent clear to light pink, and then we are going to hand irrigate. So you don't need a separate order to hand irrigate PRN. So basically, and then for the documentation, for continuous, just to tell why are we doing this, we're using normal saline, here's the date and the time, and then this is what I was saying. So the amount of saline that goes in, the amount drained, and then true urine will automatically pop up, and then you're going to describe what the urine looks like. So super important to make sure that we're documenting on this bag. Every time we go to empty the Foley, we should document, okay, right, this is what went in when I emptied it, and document both. And then if you, it's the end of your shift, you want to write where it was at the end of your shift. And yet again, you are going to be emptying. You should always empty that, even if it's not full, at the end of your shift, and you want to document on here. That way the next nurse coming in knows how much to take credit for. That's probably one of the most important things to remember. So as long as the patient's doing well and we have pretty good light pink urine, we just kind of keep it going, and eventually the doctor may say, okay, let's turn this off, we'll leave the 3-way in. If you were to stop the CBI, you can certainly just put a plug in here. You would disconnect the tubing, and you would just have to put a stopper in there, and then it just acts as a normal catheter.